Hi, so in this video we will read about birth asphyxia, hypoxic ischemic encephalopathy and neonatal seizures from marrow adhesion 6. Let's start. Starting with the perinatal asphyxia, impaired gas exchange in the fetus during the pregnancy or due to complications of labor is perinatal asphyxia. So it is basically impaired gas exchange due to any reasons during pregnancy or due to any complications of labor, and it leads to what? It leads to hypoxia, hypercarbia, and lactic acidosis. Lactic acidosis is the main feature due to diagnose the asphyxia. The umbilical artery blood pH will be less than 7. Fine. This is how we will uh, come to know that it is the baby is going under in lactic acidosis. In acidosis, okay. How the umbilical artery pH will be less than 7. WHO definition of the birth asphyxia: it is a condition that should be considered in any newborn baby wherein the baby fails to initiate breathing or not able to sustain breathing at the time of birth. Fine. This is the definition of birth asphyxia, in which the baby fails to initiate breathing or not able to sustain the breathing. Consequences of birth asphyxia: the consequences will be due to hypoxia. So what will be the consequences of birth asphyxia? It will affect the brain, right? So due to hypoxia in brain, there will be hypoxic ischemic encephalopathy. There can be multi-organ failure, kidney most common organ affected after the brain. So it can lead to acute tubular necrosis in the proximal tubule, because proximal tubules are the most sensitive one. So first we saw brain, it can cause hypoxic ischemic encephalopathy. Then in kidney it can cause acute tubular necrosis, and also there can be anaerobic metabolism leading to lactic acidosis. Low Apgar score is seen in babies with the birth asphyxia less than 7/10. Fine, this is the low Apgar score in babies with birth asphyxia. Moving ahead, due to hypoxic ischemic encephalopathy, there occurs hypoxia, that is decreased oxygenation to tissues, which leads to ischemia or hypoperfusion or inadequate blood supply to tissues. Fine, this leads to what? Ischemia or hypoperfusion and inadequate blood supply to tissues, and leading to encephalopathy or that is leading to brain injury. So first, reading about the hypoxic ischemic encephalopathy, it is the leading cause of neonatal brain injury worldwide, associated with increased risk of neonatal mortality. Surviving babies may have neurodevelopmental sequelae like the cerebral palsy or intractable seizures and low IQ. So these are the features seen in the babies who survive hypoxic ischemic injury, that is hypoxic ischemic encephalopathy. Fine. Moving ahead to Sarnat and Sarnat staging. There are 3 stages: stage 1, 2 and 3. Features: if the child is conscious. First feature that we are going to consider in the Sarnat staging is consciousness. Second one is the reflexes, Moro's and sucking reflexes, then the seizures, and then the autonomic involvement. Fine. Fourth one is the autonomic involvement, then the pupil size, and then the heart rate, then the posture. Posture, then the EEG, then the duration, and then finally the outcome. This one is the stage 1, 2 and 3. Let's start reading about this Sarnat and Sarnat staging. If the baby is conscious with a normal or hyper alert, comes under stage 1, lethargic in stage 2 and comatose in stage 3. Coming to the reflexes, if the reflexes are easily elicitable and or hyperactive, then the stage 1. If the reflexes are sluggish, stage 2, and if the reflexes are absent, stage 3. Coming to the seizures, in first stage there is no seizure. In the second stage, seizure is present within the first 24 hours only, and in stage 3 there is no seizures with no brain activity. Okay. Moving ahead to the fourth point, autonomic involvement. In the first stage, there is sympathetic overactivity. In the second one, there is parasympathetic overactivity. Okay, coming to the pupil size, in the first stage there will be mydriasis, in the second meiosis, and then the third one unequal, that is poorly or not reactive to light. Coming to the heart rate, in first one heart rate will be increased, second stage decreased, third stage variable. Posture, there will be normal posture in the first stage, second stage flexion, third stage decerebrate posture. EEG will be normal in the first stage, low voltage complexes or seizure spikes are seen in the second stage, and burst suppression isoelectric pattern is seen in the third stage. Duration is less than 24 hours in the first stage, 24 to 14 days in the second stage, and several days to weeks in the third stage. Outcome, first stage HIE children are 99% normal, second stage 80% good outcome, and 20% there will be sequelae seen, and in 50% third stage 50% die and 50% will have sequelae. So what is the normal posture that we saw here? Normal posture is the universal flexion resisting passive extension. Okay, this is the normal posture of a baby. Decerebrate posture, there is all the limbs in extension. In stage 2, 20% of the babies develop neurological sequelae, while in the stage 3, all the surviving 50% develop cerebral palsy as a sequelae. Child will not always progress from stage 1 and can present in any stage. Sarnat and Sarnat staging is also indicative of the prognosis. HIE is the leading cause of neonatal seizures. Okay. Now, this neurological sequelae depend on the area of the brain affected by the HIE. Factors that determine the area affected are the blood supply of the brain and the gestational age and the metabolic demands of the different parts of the baby's brain. So, first we are going to read about the parasagittal infarct. This is the parasagittal. This is the parasagittal cerebral injury involving what? Involving the elbow, forearm, hand, little ring, all the fingers. So, brain injury in the term babies due to asphyxia. How does this parasagittal infarct occurs? It occurs in term babies. First thing to remember, parasagittal infarct occurs in the term babies due to brain injury leading to asphyxia, and there is something called watershed area supplied between the anterior and the middle cerebral artery. Okay, see, this one is the anterior cerebral artery, this one is the middle cerebral artery, and there is a watershed area in between this one. Okay, so motor cortex and the subcortical areas are affected in this parasagittal infarct. Initially, upper limbs are predominantly affected. All the forelimbs will eventually be affected, leading to spastic quadriplegia and cerebral palsy. Initially, but upper limbs are affected predominantly, and all the forelimbs will be affected later on, leading to this spastic quadriplegia. There will be periventricular leukomalacia seen. This is an important term. Okay. So there will be this periventricular leukomalacia is seen in preterm babies. Affects the motor distribution of both the lower limbs, so there will be spastic diplegia. See? So in term babies due to asphyxia there will be spastic quadriplegia, but in preterm babies due to asphyxia there will be spastic diplegia. So there are also some other patterns of ischemic brain injury in the term babies. First one that we are going to read about is the focal ischemic necrosis. Then there can be selective neuronal necrosis. Okay, let's see focal ischemic necrosis. It refers to only one part of the brain being affected, associated with the focal seizures and hemiparesis. So there is only a part of the brain that is being affected, right? Leading to hemiparesis or focal seizure, that is hemiparesis is upper and lower limbs on one side being affected. Okay. Also, there can be selective neuronal necrosis. Particular areas of the brain are commonly affected, like the deep nuclei of the brain, that includes the putamen of the basal ganglia. So there will be extrapyramidal symptoms or hippocampus being affected. Also, there can be Purkinje cells of the cerebellum which can get affected, leading to ataxia, vertigo, and many areas are affected together. So there will be CP with low IQ. Fine. Moving ahead to this neuroimaging. So what is the screening? Neurosonogram, ultrasonogram through the fontanelles. Only a small part of the brain is visualized. Main role is to rule out significant intracranial hemorrhages. So via the USG also we can rule out any significant intracranial hemorrhages because only a small part of the brain is visualized via the fontanelles. Now the definitive imaging is the MRI of brain. In early stages, there will be diffusion weighted imaging. DWI shows the abnormality. Within few hours after the birth, there can be early changes seen. Fine. So now what is the treatment of HIE? It cannot be completely cured. Only supportive management, maintain the blood sugar level, temperature, and administer the adequate fluids. AEEG, that is amplitude integrated EEG for the bedside monitoring of the seizure activity in a newborn. Only 1 to 2 electrodes are used in this AEEG, and in conventional EEG we have 16 electrodes, and conventional EEG needs an expert evaluation. This facilitates the continuous monitoring of the seizure activity, right? This AEEG, and it helps in detection of the subclinical seizure activity in the ICU. It is only a screening test, and the diagnostic tests are definitely the conventional EEG. Treatment of the seizure is phenobarbital is the drug of choice in children, in babies. So if phenobarbital is not if phenobarbital seizures are not being controlled by phenobarbital, then we can move on to phenytoin, and then lastly to benzodiazepines. Lorazepam is the last one. Also, we can go to phenobarbital, then levetiracetam, and then to benzodiazepines. So this is the treatment of seizures in newborn. Firstly, what is the drug of choice? Drug of choice is phenobarbital. This is very important to remember. Now there is a therapeutic method called therapeutic hypothermia. What happens in this is we are inducing hypothermia by placing ice packs or cooling crystals around the baby's body, leading to whole body cooling. Or there can be also another type in which these ice packs are placed only around the head, which leads to selective head cooling. What is preferred? This whole body cooling is preferred as compared to the selective body cooling. Whole body cooling offers uniform cooling and better outcome. So during this cooling, the temperature is maintained at 33.5 degrees Celsius. What is the mechanism behind this therapeutic hypothermia? This decreases the neuronal injury by decreasing the neuronal apoptosis, decreases the production of free radicals and nitric oxide, decreases the production of excitatory amino acid, glutamate, and decreases the incidence of seizures. Fine. So this is what is happening. What is being decreased? Neuronal apoptosis is decreased, free radicals, nitric oxide is decreased, excitatory amino acid, glutamate is decreased, and incidence of seizure is also decreased. What is the so coming to the criteria of therapeutic hypothermia. Post-menstrual age of more than 36 weeks of gestation, birth weight of more than 2 kg, and stage 2 or stage 3 hypoxic ischemic encephalopathy. They should be started, this therapeutic hypothermia should be started within 6 hours of the birth, and duration is 72 hours. Fine. What is the criteria? More than 36 weeks of gestation, more than 2 kg, stage 2 or 3 of HIE, within 6 hours of birth for 72 hours. Moving ahead to types and etiology of neonatal seizures. Here 4 types are described. First one is the subtle seizure, second one is the clonic seizure, third one is the tonic, and fourth one is the myoclonic. Let's read about the subtle seizures. They are the most common type in children. They have minimal manifestation. There will be ocular movement seen, orofacial lingual movement seen, and limbs movement will be seen. In ocular movement, there will be deviation of the eye or continuous blinking of the eyes for few seconds. In orofacial lingual movements, there will be continuous chewing movements, and in limbs, there will be cycling movements. So, seizure generated impulse is not transmitted rapidly in immature brain. Okay, so that is leading to the subtle seizures. clonic. Focal clonic has the best prognosis, and the tonic and myoclonic has the worst prognosis. In this clonic type, no, there will be rhythmic and repetitive jerking will be seen, but in this myoclonic one, there will be uh, very sudden jerks which last for just few milliseconds. Okay. Moving ahead to the etiology of neonatal seizure, first one is the HIE, hypoxic ischemic encephalopathy, that is the most common one. 50 to 60% within the 12 hours of first day of life. Second causes can be metabolic causes like hypoglycemia, hypocalcemia, hypomagnesemia. So yeah, metabolic causes can lead to neonatal seizures. Infections can lead to neonatal seizures like the sepsis or the TORS infections. Intracranial hemorrhages can lead to preterm neonatal seizures like in preterm. There can be intraventricular hemorrhage. In term, there can be subarachnoid hemorrhage, which has a good outcome, right? And this intraventricular hemorrhage is seen in preterm. Developmental defects, congenital anomalies like anencephaly can lead to this neonatal seizures. Also, pyridoxine deficiency, which is dependent seizures. It is a rare cause of neonatal seizure, typically manifests as refractory seizures. Fine, this pyridoxine deficiency manifests as what? Refractory seizures. So what happens is glutamate is increased. There is an excitatory neurotransmitter and it is being converted to GABA, which is an inhibitory transmitter via this glutamic acid decarboxylase, and for that pyridoxine is required. So if there will be pyridoxine deficiency, inhibitory neurotransmitter will not be formed and there will be more number of excitatory neurotransmitters which will lead to seizures. How will we manage this neonatal seizure? The rule is TABC. First we have to look for the temperature, airway, breathing and circulation. Just T is being attached before this ABC that we already know. We have to correct the hypoglycemia or hypocalcemia if present. Then the anti-epileptic drug therapy, first line is the phenobarbital, second line is the phenytoin followed by benzodiazepine, and for refractory seizures we have to give a trial of pyridoxine. So this was all about this chapter. Thank you.